We sometimes, Archana and I started this last salon. We had some of the speakers from the first panel join us. In fact, most of the speakers joined us, but this panel got filled, so so we have Michael back, which is a good thing because this time we're probably going to ask similar questions. We're going to talk about similar things, but we do want to be a bit futuristic. This is when will robots be our doctors? So we'll try to take it more out there into what is going to happen 10 years from now, 5 years from now. So Michael, I know you have a lot to say about this, but I guess first we should probably introduce our panelists. And same thing as before, we're going to ask each panelist to introduce themselves, but quickly share a soundbite how you are reinventing the doctor.
I go first? Okay. Michael Avermore. Oh, sorry. You go first.
No. You go first. And yes, go ahead.
So our goal is also to kind of ask, how you arrived here to some sound bites, and what is your investment theory and philosophy? Okay.
So Michael Avermore, founder and CEO of IDX, and also
Yes, and please say if you're a doctor or not.
I'm Mike. And so we created the first ever autonomous AI that makes a diagnosis by itself without a physician present. It was FDA approved last April, 2018, and this May, for the first time ever, an autonomous AI CPT code was created, and that's really my biggest achievement.
Hello, good evening. Unity Stoakes. I'm the co-founder of Startup Health. I got into health really from the technology world. So I'm not a physician. I came out of the world of technology, innovation, data of the early 90s. Grew up on a farm in Iowa and used to milk goats as a kid. So here I am in the Bay Area now, focused on health innovation. Really, how I got here is focusing on a dream of opening up the world of technology and data to transforming health for not just everyone in the U.S., not just transforming things like workflow, but really opening up health innovation to 7.5 billion people. So at Startup Health, our mission is to really transform global health by investing in thousands and thousands of entrepreneurs that care about the future of health, that are reinventing the future of health and connecting these entrepreneurs together to do that. So look forward to talking about where we are in terms of not just reality, but where maybe we're going in the future.
I think I have one. This works. Hey everyone, my name is Ali Tamaseb. I'm not a doctor. I'm a biomedical engineer by background, neuroscientist, former entrepreneur, and now with a venture capital firm called Data Collective, DCDC. We invest in deep tech, so companies that are solving very hard problems with very hard technologies. One of our thesis areas is computational care, is applying hard tech, applying data and machine learning to solve healthcare problems. Some of our companies, Carbon Health, Subtle Medical, Bay Labs, Carius, Freenome, etc. And the way we look at this is a lot of data and a lot of things that's gonna it's gonna be hard to replace the doctor, so entrepreneurs need to do the hard thing, and we're there to help them provide a capital.
Thanks. It's hard to tell this one. Yeah, my name is Ian Tong. I'm a doctor. I'm an internist, clinical assistant professor at Stanford for the last 12 years, and I'm the chief medical officer of Doctor on Demand. You can think about us as a national medical practice in all 50 states, but it's all entirely virtual. So patients access us from a mobile device or from the web, and Doctor on Demand figures out how to load balance the practice so that you can have a doctor available to you within 5 minutes virtually. We started very humbly as an urgent, bit of an urgent care. That was not my ambition, but we wanted to start to see if we could prove the concept and take care of very simple, low complexity conditions. Also, that was what the market would give us at that time, because most people 6 years ago did not really know and even much explanation about what telemedicine was or what virtual care was, which some of you may find unbelievable, but that was the starting point six years ago. And at this point, we are the first virtual primary care practice. We just released so one of the ways we're reinventing the doctor is we just partnered with Humana to create a health plan that is a virtual health plan. So basically starts with virtual care, virtual primary, and then is surrounded by or supported by brick and mortar practice.
I'm Hiroomi Tada. I'm actually a surgical oncologist by training. I've spent 12 years in pharmaceutical drug development, primarily in cancer research. And I'm the chief medical officer at Notable Labs. We are a small biotech. What we look for is personalized treatment options for patients with blood cancers. We take their tumor cells. We look for drug sensitivity, and we look for specific combinations of drugs that are most effective for these patients. We're in the process of initiating some clinical trials to see how well our technology can predict patient outcomes. It's been a fun ride for the last 6 months that I've been there.
Hi everyone, I'm Malay Gandhi. I'm not a physician. I work at Evidation Health. We build technology and systems to measure health in everyday life. So we're not so much interested in replacing the doctor. I think what we're interested in is the 99.97% of the time that you're nowhere near a doctor. You're not in the doctor's office. You're going about your everyday life, not really in the 0.03% of life that you spend in the doctor's office, and how to measure health within that context.
Great. So I think we'll do something very similar to the last one, which we won't jump around, but we want to take a deeper dive with each one of you, so everyone can understand what each company does or what your investment thesis is. So we can start with you, Malay. So
you're in the hot seat.
So you're and
You're in the hot
everyone
seat.
was really good about asking questions to the entrepreneurs up here. So feel free to jump in as well as the other speakers. So Malay, Evidation Health just did a study with Eli Lilly and Apple to, I guess, detect cognitive decline in Alzheimer's. So how do you take that data and create a screening tool that's useful for the doctor?
Yeah, I mean, I think one of the things that companies are very passionate about is being driven by the science and letting the research lead us where it does. So I'm going to put a bunch of qualifications down before we talk about screening people for Alzheimer's, which is probably one of the most extraordinarily difficult challenges, in medicine. We ran a feasibility study. The study was done, we started planning for it in the first quarter of 2017. So people probably know what Apple devices were available at that time. So we're using a Watch Series 2, we were using an iPhone 7, we were using an iPad tablet along with a bedded sleep monitor. We had about 130 or so people in the study, including a little over 30 that we would describe as symptomatic. So they had mild cognitive impairment or mild Alzheimer's disease. It was a site-based study. We sent people home with devices, and what we learned through this study, I think number one, I was there when we did the first readout of the study results. The first bullet on the first page with all of our partners just said, we collected the data, period, end of story. It was a very, very, anyone who's worked in the Alzheimer's space knows how hard it is to actually run studies of individuals with Alzheimer's, to work with caregivers and everything else. So first point of the whole study was feasibility. Could we actually collect this amount of data? And it's a tremendous amount of data. It's about 2 gigabytes per person per day. If you look at the actual individual data streams we were collecting, more than 100 channels of data we were getting in per participant. So you kind of have all this raw sensor data, all the phone interaction data, what are you tapping, what are you typing, what apps are you sort of using, and then actually a pretty large volume of unstructured binary data, audio and video. So how are people speaking and talking, and then we would have them do some video work. What we learned at the end of that, again, first bullet, we collect the data, feasibility study. What we did, we were able to find class separation between the mild AD and the MCI, and then when we ones, folks with mild cognitive impairment and mild AD together. We call them symptomatic. We were able to classify them versus the healthy controls as well. So it's a cross-sectional study, not a longitudinal. So I can't tell you that somebody is going to progress and develop Alzheimer's, which I think is what a screening tool might do, is find who's high risk, who we think is likely to develop the condition. Because the study was cross-sectional in nature, it asked a classification problem. So could we put a person in the bucket? And the answer was yes, we could. And it's a lead-in to a longitudinal study. We hope that will start to answer that question.
Well, so assuming it works, from an economic standpoint, what is it just Apple just wants to sell more devices, Eli Lilly wants to sell more pharma, you make money on, how does the money, economics work here?
Well, I mean, I think, I don't know if there's any neurologists here. Maybe somebody more qualified than me. Like, I mean, you know, just in terms of healthcare problems to go solve, Alzheimer's disease and related dementias is the largest global healthcare problem we face. The whole world. I'm not talking about Americans. I'm literally saying in the world, this is the largest unsolved problem in medicine. I mean, there's lots of diseases out there. There's lots of conditions. So this is the biggest, like, forget Apple making money, forget Eli Lilly making money, forget Evidation making money for a second. This is everyone's problem. It's why Bill Gates, it's why Jeff Bezos, everyone. Bill Gates is putting in tons of money to find an early screener. And the reason why is it is a neurodegenerative disease. It is literally destroying and eating your brain. And so if we can't find people early, there's no way to treat
No, I'm not diminishing the value, I was just curious if Apple
I'm just-
really cared about the data or just really cared about selling more of these devices,
Well, I mean, I don't work at Apple, so I'm not going to represent their position, but they stood on stage just 2 days ago and announced 3 large-scale research studies that they're doing. I think that their commitment to health is, I don't know how to describe it. Their CEO has said that health is going to be the company's most important contribution to humanity. I don't know of a more committed technology company from a resourcing, like, This is where Apple is. We can let our. No, I'm just saying that you're asking a question. Like, do they want to sell more devices? Well, that's their business, sure. But I think that they're interested in making a contribution to human health.
And coming back to almost kind of the charter of like reinventing the doctor. So yeah, Eli Lilly and Apple being other players in the playground, so to say. How is Evidation Health with a study like that or other work like flu forecasts and other things? How are you helping the end user, which is the provider, and helping them to reinvent either their workflow or the patient outcome, patient experience?
We don't think of them as the end user. So I mean, I think we should.
So who is your end user?
Yeah, we can talk about it. So I mean, I think like Apple, they have if you're wearing a watch, you better turn on the irregular rhythm notification. So it purportedly tells you whether you have atrial fibrillation or not, and it can take an ECG. And when that was released, there was a lot of questions from cardiologists about this. And what will this sort of look like for us? I would be curious from Ian, are people hitting the doctor on demand button saying like, I got this irregular rhythm notification, what do I do? Dr. Gottlieb, Scott Gottlieb, who was running the FDA at the time that they received their 510K clearance, he tweeted out and said, we're getting a lot of questions about this, but just to be clear, they followed the rules, they got a 510K clearance, like we didn't do anything, nothing was special here, 510K rules have been on the books forever, and as a doctor, you need to figure out how to practice medicine in this world. If consumers decide to buy the device and they get the notifications, then you as a doctor need to figure out how to practice that. So Evidation operates a consumer app called Achievement. Over 3 million people have sort of signed up for it. We operate what we believe is the country's largest virtual site to conduct research. Our view is we're going to empower people. It's not really our job to figure out, how that works with physicians. I absolutely hope in the future we can work with them and figure out how to incorporate what we're doing in the practice of medicine. But I think a lot of these things are so early. Our focus is 100% with the individuals and helping them better understand their data and how to be useful within the context of their own health. And I'm probably I'm not speaking for the company, on a personal level, I'm kind of with Dr. Gottlieb, like the world's changing, you gotta kind of adapt and figure it out. Like, people are gonna make the choices they're gonna make.
Yeah, so reinventing the doctor is also kind of reinventing that interaction that they have with the patient, which is also, it's kind of your end user in a way. right? So you're doing studies that is driving data and giving it in the hands of
Yeah.
consumers, or so to say, patients, right? So how are they using this data?
I guess I couldn't tell you specifically how they're using it. I guess the thing that I would say is something that we're passionate about, interested in, is medicine has talked a lot about shared decision making for a long time. I don't know that the ground has always been level in having a true shared decision making conversation. I think it's still been the idea that the physician brings the information and then we together work. And I think our question is, how does the information come together? So, and I'll let you say the thing in a second. We have to accept the premise and a world that's coming where the patient knows more about their doctor. And I would argue many patients living with conditions their whole lives, chronic conditions, know way more than their doctor who trained for 10 years or 12 years. They've been living with it their whole life. So there are things that they know more about like their own health, their own condition than their doctor does. With this data, I mean, like the things that we're doing, this isn't like Liz Rocket was here talking about Google symptom search. I mean, that's just garbage. It's just bullshit. It's not personalized to you at all. We're talking about like FDA cleared models. We're using actually objective data to understand somebody's health. So people are going to walk into their doctor's office with that. And so I think the interesting part of that is what does shared decision making look like when it's not totally asymmetric? One person with the information saying like, hey, let's have this shared decision making, but I know a lot more than you do, versus, hey, both people might have something to bring to the table.
That's great, thank you so much.
I just want to jump in on that a little bit, and again, can I pull a little closer? I agree with you. I think that, for one, if you want to drive towards a shared decision-making model in the future, absolutely there's disequilibrium between patient and doctor right now. As a doctor, I actually do want to know that information that's happening when you're outside of my office, right? I have this, I get 20 minutes with you, and I think someone was saying and making that 20 minutes sound like it's a lot of time. It's actually not quite a lot of time, depending on how many conditions or comorbidities your patient is actually dealing with. That's one area that I'm allowed to ask a lot of questions about, and that patient expects that I'm going to ask questions about. They don't know that I'm going to ask questions maybe about their social determinants of health and all the other issues that I think are really happening to them outside of the doctor office. And so if I was in a healthcare system, so I'm a doctor on demand now, but I did a lot of work at the VA. My first 8 years of my career was at the VA hospital, where we are the payer and the provider. And so knowing, having a tool that allows me to know which patients are going to need downstream caregivers and are going to need transportation. And so I can see both medical crises being able to be avoided, but I can also see indirect costs being minimized just by being able to put things in place at the right time for the right patients. This way, I stole yours.
I think, I love technology, but more than many doctors, I think, but there is this problem of, if you generalize this, that if you do 1,000 tests, 50 will be abnormal by definition, right? And so you're going to have to chase as a doctor, because eventually someone's going to the healthcare system with, hey, my Apple Watch or whatever gave me these 50 tests that were all normal, what are you going to do about it? And so you are affecting the healthcare system.
You hold the mic close up.
Sorry. Yeah, I will have to repeat my argument.
You're making a false argument. It's not that hard.
It's 1,000 tests. I mean, by definition, just statistically 50 will be abnormal, and so if you have an Apple Watch that is giving you 50 abnormal tests, you can do that to the healthcare system. Doesn't need to be a doctor, but someone needs to deal with that and takes a responsibility and liability for this. So eventually, you will interact with the healthcare system. And so we do need to figure out how. You can say, well, it's about the patient and they're on their own, but eventually it will affect them.
Yeah, there's false positives in any type of assessment. I mean, I think that's just the nature of things that we're doing. I think that, I'm not saying that we won't interact with the healthcare system. I think, though, the one thing I would ask is that we step back and look at what is different about this form of monitoring than what we've done in the past. So first of all, I have the priors, so I actually know whether I should be seeing a positive or a positive or negative result. So Bayesian-wise, we should be able to lower the false positive rate. That's one. Two, I can continuously sample. So I don't need to do a one and done test shot of like just let me have one test on the person. I can actually track and follow them. again, I don't work at Apple, but you can read the documentation on how they actually trigger the alert and what needs to happen. It's not based on a one and done shot. And I think they have the opportunity to collect a ton of data, more ECGs than anyone really, on the planet. And so it feels better. I don't know if it's right, but it feels a little better than what we're doing today.
Yeah,
Malay, can I ask a question, Malay?
Yeah.
Hi, so I really like what you're saying. You sound like a super smart guy. But as someone who sees patients every day, and I've watched this whole process of informing the patient and living in the Bay Area, where people come in with a Google search, still it's a minority of patients who truly want information. As a rule of thumb, they just want me to solve their problem or series of problems, literally with the least amount of change in their personal lifestyle as possible. And this idea of empowering patients been for decades now, and I'm just curious, now maybe neurology is a little different, maybe taking use cases, but from your experience to date, is the question, how many patients are you seeing taking that information you give them and then actually acting on it?
I don't know. It's a phenomenal question, and I mean, just so you understand, like, Evidation probably had something like 20 peer-reviewed publications in the last 2 years, and I'm not like bragging about that. I'm saying that we're in an R&D phase of what we're doing. Like, we are truly about the future. We are not about today. And so when we think about our business, we think about like sort of research, and then we think about delivery. Our company is just starting to find some things that we think are interesting enough to test on the delivery side. And so one area we've spent a lot of time on and worked quite a bit on is in migraine headaches. And we think we're pretty close to doing something there on the delivery side. We're testing exactly the question that you have. And the first thing that we do is we come out of a study, let's say with about 1,000 people. They've been wearing their devices and helping us by doing these extensive daily labels of like, did you have a headache attack? How long was it? Like going through the entire sort of ICHD criteria, so we classify each one for months. The first thing we do, at the end of the study is give them a report back. I mean, it's the minimum they deserve is something back. They did all of this work for us, labeling and research, and then we do ask them, did you talk to what did you do with this information? A shockingly high number of people went and talked to their physicians because they didn't really have any quantification of what their headache burden was. So I don't know. I think it is probably the central question we are most interested in is how they activate. Another thing I'll say is we have a study running, not in San Francisco, at 18 sort of like aging communities. So it's like the third largest adult living community. They provide a wide spectrum of care from just straight independent living to skilled nursing, and we're working with that, the group that's healthy today, but maybe won't in the future. And we're just doing a long-term study of aging. We have about 1,100 older adults in, and we've given them devices and everything else. It's about 1,100, and I kid you not, at 3 a month we've seen, we're about like 20 months in or something, and 11 months in on a Series 4 watch device. 3 a month, and we're not studying cardiovascular disease. I swear to God, we don't ask them to use the feature, we don't teach them how to turn it on, we don't tell them to take ECGs. 3 a month reach out to us and say, like, my alert went off and I went to the doctor. And I don't know, we're just kind of surprised by it. I don't know if they're going to go out and buy the devices or not, like on their own, but we were shocked to be receiving that feedback and input from it. So it was a great question. Sorry, I don't have a perfect answer.
I want
It's
to
about where
switch
that
gears a little bit here, talking about empowering the patient and consumer, but how about empowering the doctor? And so, Hiroomi, you are trying to do that with your personalized cancer treatments, and you just went through a clinical trial. I guess one of the things that you have to show that you can achieve is that you can actually get studies or you can get results in faster, right? That's what doctors need. So just first of all, explain that you're helping physicians determine which treatment to choose for a particular patient, a particular cancer patient.
So I think, as we, particularly in oncology, we start.
Hiroomi, can you hold the mic a little bit closer?
As we, at least in oncology, we talk more and more about personalized medicine, precision medicine. And the thing I worry about is that, when we aggregate a lot of data and we get a lot of sort of regression to the mean, you end up treating everyone the same way, right? It's still a one-size-fits-all kind of solution in medicine, that there's a standard of care that everyone should be treated with. Even if their cancer, even if they have a specific kind of a blood cancer that might be different from another patient's specific blood cancer. So the approach that we look at is what makes each of these patients' blood cancers different from each other. So, for example, in acute myeloid leukemia, one patient has very different mutations than another patient, but we don't know how those mutations affect their ability to respond to certain chemotherapy combinations. So what we do is we actually take blood from patients. We're not Theranos. Right? This is, we take a regular tube of blood now, a little prickle. Multiple tubes. And we look at the cells that are in circulation. We test them on. We have a fully automated system that's able to test hundreds of drugs and drug combinations, all in a high throughput manner. We can turn around the information back to the physician in 3 to 7 days. And the study that we just completed with Stanford, we had actually 85% positive results. If we said that a treatment was going to work for this particular patient with blood cancer, and that physician decided to prescribe that medicine, 80% of the time we were correct. Or if we said that there were three, the top 3 hits, they decided to go with something else. And we had happened to test that. If the patient didn't respond, they also had that they would correlate. Did we predict that that patient wasn't going to respond to that? So it's a small data set. We're just in the process now of expanding the studies that we're doing. Actually, we're doing a much larger clinical trial in the next 12 to 18 months. But what we hope is that we don't end up in a situation, for example, multiple myeloma, where patients who have failed the first-line therapy, there are 7 or 8 different treatments that are approved for them. The doctors have no idea what they're prescribed for. You just kind of go through the list, one after the other after the other. If you're able to actually tell a doctor this drug or this drug combination for that patient at that patient's point in the treatment journey, that's highly valuable information.
And so how are you putting this valuable information in the workflow? And then how is that going to help the provider and help the patient work on cost and efficiency?
So right now, this is still a research platform. So most of the work we do some work with pharmaceutical companies where we take their drugs and we test them across a variety of different patient samples with AML and MDS and let them know whether or not we see activity in specific subgroups of patients and what combinations of drugs appear to be efficacious across the largest number of patient samples. So those are samples that we don't actually have much clinical correlation with.
So in the future, we talk about the future of reinventing the future of physician. How would your solution change the management of cancer patients or even beyond? What would that look like?
So our midterm goal right now is to change the way clinical trials are conducted. Right now, if you go on a cancer trial, about half the patients go in a control arm where you either get standard of care or even a placebo. So what our vision is for the near term is to design clinical trials where we know up front these are the drugs that you're most likely to be responsive to. We're gonna get those drugs into the arms of the different trials, and we're gonna put those patients on the arms that are most likely to respond to. So that you decrease the number of patients who go into a control arm, but also give patients back an advantage. Right? That you're not just being randomized 50-50 to a treatment that may or may not work for you. That if you're going to go into a clinical trial, we should at least give you an opportunity to respond to the medication.
What do you see the future will be for solid tumors in this technology?
So that's tough. So I'm originally from Philadelphia, and I look at it this way: solid tumors. When you take a biopsy of a solid tumor, it's like taking a poll in South Philadelphia, and basically generalizing it to the entire population of Pennsylvania, right? What the biopsy that you take may not be particularly applicable to the entire disease burden.
If there are circulating tumor cells in the blood from the solid tumor,
Right.
you can pick up.
There are, again, that comes around to turnaround time. The advantage in blood cancer is that there is a kind of blast count or tumor burden in the blood that we don't actually have to try and expand those cells. We can actually just do a simple procedure to get rid of the red blood cells. We're left with tumor cells and other normal white blood cells, and we can do the drug sensitivity testing. Much tougher. So the company was originally started by our founder as a way to try and find a treatment for his dad who had glioblastoma. He was ineligible for clinical trials, and so his solution was actually to hire a postdoc on UCSF to grow his dad's tumor in an organoid to do chemosensitivity testing. So that was sort of the impetus behind the company.
So going from oncology to primary care or urgent care, so in the current state, let us know how you are reinventing not just the telemedicine, but also the primary care space and the provider in general. At HP, we have rolled out your competitor, the work that begins with T and ends with C. And we have seen that the engagement rate is very good.
Rolled out.
Yes, we have implemented.
I was hoping I heard ruled out.
No. So it's positive for them, not so positive for you. So I'm just kind of being transparent. But this is how the patients or employees have described to us that doing teledoc is like buying milk from a gas station. I'm out of it. This is the only place that's open. I'm going to go get the milk. That's not the repeat customer that they receive. And so the engagement rate that was like hyped up initially with the rollout, not the rollout, fell down in a few months thereafter. So can you explain your challenges and how are you even going into a fully integrated primary care?
Yeah. I think you made a number of points in there. One, I was maybe just helpful to give people a little bit of our experience. So the urgent care piece that I mentioned was really where we started out, and one of the reasons I gave was because of the general acceptance and knowledge about what was the scope of practice that was possible through virtual medicine or virtual care. And so what we've learned over the years was so first of all, 6 years ago, I did not know what could be done myself. I had a pretty good idea because I'd actually developed some telemedicine clinics at the VA in the first 8 years of my career, and so I had some idea of what I thought could work, and I thought leveraging technology would do at least one big thing, and the way that we did the VA was to improve access. And so I can see why a lot of virtual care practice would want to sell on the gas station model for the milk, which is like, it's easier to access, it's very convenient. I like using access more than just convenience. I think convenience speaks to the value proposition for the patient in a way, but I think it minimizes what can be done. So to get to what we've learned over the 6 years is patients certainly get convenience. They do get that. They get their milk and but they can actually get some other things too. They can actually have a conversation about their diabetes or other conditions if the doctor is board certified or knowledgeable about that topic and is given enough time to spend with them. And so one of the interesting things that we learned was in my brick and mortar practice, it takes about 20 minutes to have a typical visit. On our platform, the average visit length was about 8 to 9 minutes. And so it was taking half the time. So I was curious about that and actually a bit skeptical of it. So we asked our patients and surveyed them, did the doctor spend enough time? These are CG CAPS questions. So did the doctor spend enough time with you? Did the doctor listen carefully? Did they treat you with respect? And overwhelmingly, we scored at the sort of above 90% for yes for those questions. So the idea there was, and what we were saying was that it didn't necessarily take 20 minutes to cover the material that needed to be covered. We asked the patients, or we actually assessed the patients' verbal feedback on and what they would write when they gave us a 5-star rating. And what was interesting there was they actually said, we categorized the comments, and most of them, the largest percentage, were scored as establishing rapport. So patients were feeling that the doctor was establishing rapport with them. So patients are getting access. They're spending less time in the care episode. They're establishing a relationship with the doctor in a way that we were not anticipating. So I think for doctors, in one way, it's like, oh, I can do a good job potentially in less time, and the way we rolled out the service was at lower cost.
So you talked a lot about the benefits already to the patient. So you're collecting so much data. How are you leveraging that data to, in the future, offer more engagement or a better patient experience, or to offer broader services to the patient?
Yeah. So so maybe just say a little bit like, what data do you think? Which data? Because you're right. We get a lot of data. We get patient-specific data. So the doctor does. We have an EMR that we built in-house. We have, so the traditional, to keep it simple, the traditional SOAP note that a doctor would create from a visit. So we have diagnostic data, we actually order labs, so we have a lab integration that allows us to perform both screening labs, but also maintenance labs on our patients. So we have that traditional EMR type of data on a patient.
Yeah.
But we also have a lot of data on like the process of what happened, like how long did the patient wait, how well did they convert from one part of the app to another, the average duration of a visit, whether a medication is prescribed. So we have a lot of, I think, sort of process and clinical process data.
So I think we should probably bring in Ali and Unity here. And so just to put you guys on the spot, which of these 4 companies get you the most excited?
That's a good question. I'm not here to judge that. But I think we need very different parts of the spectrum. We need the primary care, we need diagnosis, we need Alzheimer's is the biggest problem. I agree. And we're seeing what's a clinical action point after the diagnosis. Are we catching these early enough for us to be able to make any change in the course of action? And obviously in cancer and diagnosis, see a lot of activity from other companies.
Do you see in your investment space that a lot of solutions are coming in where we are moving decision-making from the provider to the patient? So we're giving them really clinically validated tools, so they are doing some of their own decision-making.
I hope so, to some extent. So at the end of the day, I feel like to get back to the whole theme of our this data and robots replacing these doctors, probably not. I don't think so. Not anytime soon. But it's augmenting doctors, and it's augmenting the patients by giving them more information. And as you said, if you have more information in the hands of the patients, they know themselves better. They would know what their problem they have. It's better. So it will help. I think if you break it down to the diagnosis, the intervention, the treatment, and prognosis, it can probably help very much in the first and last step. But you need the doctor to go in and make the treatment, and I don't think robots can do the treatment anytime soon.
How about you, Unity? You invest in moonshots.
I think just all 4. I mean, when we launched our last company at Matt Holt's first Help 2.0 conference, that was like 13 years ago, there was like 6 entrepreneurs running around focusing on health innovation. So just the fact that there's a whole new generation or generations of different types of innovation going on is inspiring and amazing and awesome. My sense is that we're in this, what I like to call the moment of, there's this health innovation paradox going on, where innovation's happening faster and slower than we think at the same time. So probably 95% of the innovations we see or talk about today are these very incremental progress, things that are fixing something very specific, potholes along the highway today, and very essential to future innovations as well. At the same time, there's this whole parallel pathway of exponential innovation going on. When you hear about connecting computers to brains and the possibility of telepathy being possible, and that's like a whole nother level of innovation. And there's actually a lot of progress today of robots replacing doctors in very significant ways that are happening already today, whether it's miniaturized surgeons embedded into your body, or augmented technologies that are empowering physicians or clinicians and transforming even basic things like the workflow. Or there's a cool company I just met recently out of Berkeley, some young folks there focusing on, it's called Deep Scribe. It's an automatic scribe. There you go. That's an incremental innovation, also very awesome innovation, but at the same time, there's these transformative innovations. Both are essential, both are happening. And Malay, back to your, how we started the conversation, when you have a company like Apple coming in and basically putting clinical grade sensors on billions of people's wrists or around them, the opportunity over, say, the next decade is profound. Couldn't even imagine where that goes at this point.
What about the opportunity for,
So I have a question for you, Unity, since you kind of sit in this universe kind of at a high level and see a lot of different things. When we're talking about reinventing, the clinic or the doctor, I have a son who's pre-med, and he is taking the exact same courses I took when I was an undergraduate biology major at the UC, and he's at a UC. And I wonder, what are we doing to prepare these young people so that they are able to assess and read and evaluate this information that's coming to them? Because at this point, I'm hoping when he gets to medical school, it'll be a little bit different, but it's the same thing I learned.
And I think that's kind of the physician dilemma that most providers are having, whichever generation they're in. And I almost feel the future of physician looks like just like an RN works with us. There would be another line of service that would work, that would deal with all the noise. And I would say noise because some of this is noise and not actionable. That person will become the triage, just like my nurse is a triage for a lot of calls that comes or portal messages that come, and then you triage them to make it actionable for the MD. It's almost like, Evidation may send 15 or Apple Watch may send 15 alerts, and then that person or that role will start triaging those, and then will come to the nurse, and then will come to the MD. I believe and I hope really that's what the future looks like. It becomes much more specific and actionable, role-based, and not so much education-based. Yes, go ahead.
So I have a comment.
the medical education system hasn't changed for over 100 years since Abraham Flexner wrote the Flexner Report, supported by
I
Carnegie.
agree with that.
So this is like not just like one generation, this is a very long-standing issue, right? So having done medical school in the not too distant past, I would say that I got about 2 hours of formal instruction on EMR usage. And of course, if you look at the first year resident, depending on where you look, time spent in front of the HR, there's logs. This isn't just survey data, there's actual log data of time spent in machines. Averages 6 to 9 hours a day. So like where people are actually spending time and the balance of where education is falling are at significant divergence right now. And hopefully the HR systems will improve and how they integrate, and a lot of systems will move to mobile and voice and a lot of other things. But your point is, I would generalize that as to being a long-standing issue in medical education.
I just want to make a point that I used to spend 6 to 9 hours looking for charts to read. So, when it was an 80-hour work week, and we didn't get 40 hours a week off to go play. So it's a different thing, but so we're moving in the right direction. You don't need to teach anybody to use EMR. It's getting to the point now where you just walk in, most everybody has time to use it. So we're moving to the point where you don't need to learn the iPhone anymore, right? The keyboard's missing, you know what to do. Two points I want to make. There's really two fundamental issues here. One is that as long as the physician holds the pen of prescription power, the only person to make a diagnosis, nothing's going to change. And the second is because the payment model can't change without that. That's the number one thing. At some point, the FDA is going to say, we're going to authorize an AI engine to make a diagnosis. When that happens, that's the only time you'll see a significant game changer.
Alex, did you
That
know?
is when patients can carry their information around with them and become a viral vectors of the data. When that also happens, which means that all the EMRs have to be forced to share data, then you gotta have another fundamental shift. Until then, there's no need to teach anything else.
Alex, did you want to follow up on that, or no? Okay, so.
Well, I want to disappoint this commenter because, the FDA approved an autonomous AI last April, or in 2018, nothing much changed. And so, they didn't have, maybe need many more, maybe.
But we're still thinking in terms of now and the realities of now and I mean, how long has the iPhone even been around? Not very long, right? So even the concept of EMRs, like, I know Epic controls everything now, but will they always? No, it's going to be leapfrogged, right? It's just going to happen. It's inevitable. There's a big point we're missing, which is it's a big world. There's billions of people, basically most of which have no access to any care or any doctors at all. And I think that instead of robots replacing doctors, they're going to transform almost every one of us into becoming a doctor in very extraordinary ways. So those of you who are already doctors, you'll be like super doctors, and we'll all be doctors. Like, that's the potential.
He says, I'm a doctor, and
Yeah,
you're.
essentially self-decision-making tools that will help you to make decisions for yourself. The clinical decisions that are being done right now, brick and mortar, will be put in the patient's hand, and they can truly.
I have to give you
It's closer to you.
I'm a simple surgeon. I need things broken down into things I can understand. And so I think one example of how technology changed surgery was laparoscopic surgery. When I was a resident, it was just starting to be rolled out. That's how it went. Most surgeons didn't like it. They had to go through training. They had to go through this. They had to make these tiny little incisions, and there was stuff in the way, and you couldn't operate well, and you couldn't see anything. And oh my God, if you got bleeding, you'd have to make this huge incision, and it was a big mess. But ultimately, what happened was the consumer said, "I want small incisions. I want to be able to go home the same day after surgery." Right? So there are ways in which technological advances in medicine. That change can be driven by consumers.
Consumers and payers.
Yeah.
Yes.
So,
So I have a question for Unity. So we're talking about reinventing the doctor, but we educate the medical schools. They are teaching the same curriculum that they've been teaching for the last 40, 50 years. at startup health, you have many moonshots. Is there a moonshot for education to modernize the education of modern medicine?
Let's add another. I think it's a profound comment. There are some institutions that I see kind of mixing entrepreneurship with the medical schools or different kind of way, but it's just beginning. I think it's a big challenge. One of the trends we're seeing, about a third of our portfolio, we have 300 companies now, are founded by doctorpreneurs. So a lot of the best innovations we're seeing are being created or started by clinicians. So I don't know what that means in terms of academia in the future of how doctors are trained. But it's a big challenge because there's this lag, it's so anachronistic. But I would say that's a challenge across all education, across every discipline of education. It's just so far behind in many ways for physicians, but for every other area as well. So it's a big challenge.
I want to.
I have a little kind of plug-in for DocSF because I was there. I attended a few of those, Dr. Vini's, and one of the showcase was a provider who came in who had a VR device and an AR technology. He was in the UK doing surgery and was coaching surgeons across the world, and it's phenomenal. And it is starting to happen in education, healthcare education, but it's coming at the point that they have already foundational knowledge, and then it is coming to the already finished providers in a way. I wish that it starts happening a little bit sooner, but I have seen versions of those.
Sorry, I just want to comment to the last question, is that there is a lot of activity outside of the US in a lot of countries that are trying to deploy developed world level healthcare systems and trying to upskill labor force to address very, very large populations. And I suspect that you will see a leapfrogging in various kinds of medical education all up and down the spectrum, probably happening in many of places that have significantly different pressures than the US, both in terms of demand and motivation.
Can I build on that? And lower regulation.
Yes.
So you take demand, and you take me, you take lower regulation, you take AI, and you do augmented support systems. Now you get an RN who can do a level of an MD, you get a PA who can do a level of RN, you can work your way up, and now you can empower the guy in the little town in the middle of nowhere to actually do screening. Now, there were some interesting things that happened in India not long ago where they actually took iPads out into the field to diagnostics, and the biggest issue was once they took care of that, because they couldn't deliver the medication. So they got people on the hypertension meds with these technologies, and then they couldn't actually follow up with the chronic care. And now they're solving that with drones. So, it's like one thing leads to another, it creates a problem that gets solved.
Can I be conservative here? So, I teach, not so much medical students, but residents and fellows, and there's a lot traditional because there's so much science that we know works, because we're actually not doing it. So a great example is diabetic retinopathy screening, which happens, which AI does. Only 15% of the people who need it get that every year. So 85% of what we have known for decades to work and protect against blindness and what people do now. And so there's a lot of future to be done, and the future should also be that we actually do what we know works. And so the reason why I founded the company, one big reason, is that productivity in healthcare is not only staying the same, it's actually going lower. And if you know something about the economy, lower productivity means high prices, and essentially destroys it. And so IT has been usually used as something to increase productivity. And I have a technology or IT background, and it was surprising to me that EHR actually drive down productivity. They make it worse. There's a lot of evidence now that they actually make productivity lower than before they were introduced. So my reason for using AI is to actually finally use technology in a way that improves productivity. And that's the point. Looking from the perspective of the physician, you increase the productivity because now there's these machines doing it. Not because, there's more input to the primary care physician who doesn't deal with it, but from the level of the specialist, there's a lot more productivity.
Right. So we sort of have to wrap up because it's time. But I wanted to ask a futuristic question. We have the first ever, I think 8 years you started going through the FDA process, Michael, to get the first autonomous AI machine device approved. And your company has the first FDA approved autonomous AI. And that's, I don't think 8-10 years ago, we would have thought that, right? I mean, you don't have to, it's the machine that has the liability. So, and I know it's in imaging and eye disease, but I want to ask everyone here, 10 years from now, where do you think we'll see autonomous AI?
I'm gonna say where I hope it will be, I don't know, but there's one thing that always gets left out of these discussions. A lot of the process in terms of payment and revenue cycle management in healthcare is, I think, a mess. The billing is a mess. It's a huge, I think we waste a lot of money there in healthcare. That's not what we do, but it's one of those things that doctors spend a lot of money to get billers and so on to figure out this maze. And so I hope that someone spends more time figuring out that sort of not so sexy but really important part of the healthcare delivery model that we currently have. I'm happy to blow it up, by the way, as he was saying. If we could blow that up and change that, I think you will see a lot of doctors who want to change. But we have to help with some of these tools.
If I could just add, I hope it's a global solution, and a big part of that is figuring out who pays and how the cost structure works. One of our other moonshots, cost to zero. It's basically doing what Skype and WhatsApp did to AT&T and driving the cost to zero or radically transforming cost. So if we can leverage these types of technologies but open them up in places where the economic viability isn't so certain right now, that would be very, very interesting.
If I were to kind of predict, I think, yeah, definitely the biggest problem is this, at least 1/3 of the admin and payment and everything related to that cost, which, maybe IT would actually make it worse, but maybe hopefully now it will make it better. But, after now collecting the HR data for years, which has, driven the productivity down, now it's the time to actually get it back on. So, we give something, we hopefully are getting something back now with having that historical data. So going forward in the next 10 years, definitely think on the payment side, on streamlining the payment and admin stuff. We can do more upshift in the kind of skills. What can be done at the point of care. A lot of things that could be done in specialties probably come at point of care, outpatient, and just augmenting the people, the doctors with more skills. And hopefully we can by that time have more clinical actions that are being discovered by AI, machine learning discovered drugs, or a lot of other ways that we can actually intervene. I think more important than diagnostics actually intervention.
Well, actually, one thing I loved was the med quarter. So I'd love to find a way to use that, so that it becomes a part of a patient's medical record, right? So that rather than having to sit down and dictate an office note, you take that, you transcribe it, and even potentially take it and do your billing off of that discussion you had, right? We have the technology to be able to actually do that, so that it takes all of that sort of administrative burden away from the physician.
Well, there is a company called Suki that does that.
And Robin.
Yeah, and Robin, so you have two already out there.
5 or 6.
Right.
Well, and I think if you remove billing, just imagine that world. And if you don't have billing, you do not need to document that much. Because really, we are doing electronic health record for documenting. And some of that, unity that you say, or you're saying that we have harvested, we need to harvest that data. Not all of it is intelligent data. Because a lot of it, and if you have worked with Epic, and most of us have, it's dumb data. Actionable data is really, will come out if you stop doing this for the providers. And I'd come back to salaried providers, outcome basis, bonuses. That's how you can actually have providers be happy, do the right work, and remove the electronic health records, make them more productive with tools like that.
Mark, can we,
It's all good, you're ready, yeah, ready to go?
Ready to go?
Okay.
Did you make a good visit?
Yeah.
Thank you. And our next salon is November 14th. We'll be at HP. So if you go on the website, you can actually get tickets for $25. See you then.